Hello everyone. Now we'll talk about failures in fixed partial dentures. We need to know the failures and where all it can fail, where all the fixed partial dentures can fail, so that we need not do any mistakes in those particular section for fixed partial denture preparation. Starting from preparation till its cementation, there are many places where mistakes cannot to happen, and that will lead to fracture, failure, breakage, or entire loss of fixed partial denture, you can say. So classification as given by Bernard Smith is loss of retention, mechanical failure of crowns or bridge components. What all can happen in that? A porcelain fracture can take place, fracture of shoulder joints can take place, distortion can happen, occlusal wear and perforations can take place. There can be lost facings can also happen. Changes in the abutment tooth, what all changes can be occurring or we should anticipate. Periodontal diseases can be there. Problems with the pulp can be there. There can be caries, there can be fracture of the prepared natural crown or root, or there may be movement of the tooth altogether. Then coming to the next, there is a fractured abutment we can see here. Broken fractured abutment from here. Now there can be design failures. Design failures like we can have under prescribed FPDs or over prescribed FPDs. For example, under prescribed means like when we have giving a cantilever, we have no posterior support, that can fail. Over prescribed, a long span bridge we are giving which is not indicated again, that can fail. Inadequate clinical or laboratory techniques, like for example you can create positive ledge, there can be negative ledges, there can be defect, poor shape or color, or there can be also occlusal problems. Now what all the things that will come due to these things will be that there can be discomfort. Now discomfort, for example, how there can be malocclusion or premature contacts, an oversized or poorly positioned mastication area with retention of food by pontic or retainer. There can be talc produced from the seating of the bridge or front occlusion and excess of pressure on the tissue. There can be overprotected or underprotected gingival and bridge tissues. There can even happen to go for thermal shock. Second is looseness of FPD. Now looseness of FPD can occur because of what? It can occur because of deformation of the metal casting on the abutment. It can happen due to inadequate torque. It can happen due to technique of cementation, a wrong isolation not happening, solubility of the cement, caries, mobility of one or more abutments, lack of full occlusal coverage, insufficient retention in the abutment preparation. There can be poor initial fit of the casting which is prepared. There can be casting defects. Now there can also be recurrence of the caries. Now what all the things we should be expecting with recurrence of the caries? That is open margins, short castings can happen due to recurrence of caries can happen because of that. Overextension of the margin can also lead to caries, where a retainer becoming loose is also another important factor that we need to keep under consideration. Pontic frown that fills up the embrasure place. Poor oral hygiene maintained by the own person. Use of a wrong type of retainer which will promote caries susceptibility, or permanent displacement of the gingiva due to temporary protection can also recurrent. Use of caries, recurrency of the caries can increase because of that. Now recession of the supporting structures. What all the things we should see if there is a recession of the supporting structure, how it will come up to. So length of the span that we have given our fixed partial denture, or size of the occlusal table, embrasure forms, or fewer extension of the cervical margin. Impression technique and also suitable recession of the gingiva. There can be degeneration of the pulp as well. Fracture of the bridge components. Now what are the fracture components that can happen? A faulty solder joint that can fracture the component. Incorrect casting technique can fracture the component. Overwork of metal due to length of the span or the parts that are too small can also fracture the bridge components. Loss of veneering. Now, loss of veneering is like little retention is there, or badly designed metal protection, or there is deformation of the protecting metal, or there is a malocclusion present. Improper fusing or technique which is used can lead to loss of the veneer which is there on the top. Also, loss of the function. How is that possible? They don't function in occlusion if they do not contact with the occlusal teeth. If they have permanent contact, and overcarved or undercarved occlusal surface may impair efficiency. Loss of opposing or approximating teeth can also lead to loss of function. Now coming to loss of teeth tone or form, so the different pontic design into fault can happen. Posterior or the position and the size of the joints that we are giving can lead to loss of the teeth tone or form. Embrasure form is another important thing that will, consider the loss of teeth. Over contouring or under contouring of the retainers. Oral hygiene, practicality by the patient, and oral hygiene, if it is not maintained by the patient, can also lead to the loss of teeth, tone or form. Coming to failure to seat. The abutment preparation may not be near to parallel. In that case, it will not have a single path of insertion and the seating will be not proper. Soldering assembly may have been incorrect, or relationship of the retainers may have been altered during soldering, can also lead to failure to seat of the particular restoration. Now, what are the types of bridge failure? It can be cementation failure, it can be mechanical failure, it can be gingival or a periodontal failure, it can be due to caries, susceptibility and recurrence, it can be necrosis of the pulp, it can be a biomechanical failure altogether. We'll discuss all this thing in detail. We have aesthetic failures as well. Coming to the first one, that is cementation failure, which can be divided, or cementation failure, how are those can be divided into? It can be divided into if the cement fails by itself, if the retention is a failure, if the retention is not proper due to cement, occlusal problems are there, or distortion of the FPD takes place. Cementation failure, adequate working time is not there, which is not providing a good apical seal, or it is toxic to the pulp, do not have that low viscosity and solubility characteristic, or it does not exhibit good working time and setting properties. In those cases, cementation failure may take place. Similarly, retention failure may occur due to different other reasons, that if the cement which is being provided doesn't seat properly. So what is next? Coming to the retention failures, what are the causes for retention failure? It can be excessive taper, it can be short clinical crowns, it can be misfit of the crown, or it can be misalignment or a malalignment of the crown that we are giving, can also lead to retention failure. Now coming to occlusal problems. The occlusal problems can have immediate problems, or it can have a delayed problems. Immediate problems like occlusal interferences, there can be marginal ridges at different levels, supra-eruption of an opposing tooth, or it can have parafunctional habits. Delayed problems, for example, wearing of occlusal surfaces, loss of occlusal contacts between the teeth, perforation of occlusal surface due to porcelain versus resin or porcelain versus gold, full lodgement due to the plunger cuts present in the opposing occlusion, fracture of the facing due to defective occlusal contact, periodontal or gingival breakdown can also happen due to improper occlusal contacts, tenderness due to foot lodgements can also lead to occlusal problems. Now coming to distortion of FPD, when it is distortion of FPD, we have to find for the marginal integrity of the patient. So what are the causes for failure in the marginal integrity? It can be bending of the FPD, that is in the wax stage, or removal from the die, or the sprue stage or investing stage. Incomplete casting can also take place. That can be where the wax pattern is too thin. Incomplete wax elimination or cold mold or melt or inadequate metal which is present can also lead to fracture in the marginal level. Also, if the casting is not proper, we have not used improper water powder ratio. If we have used improper water powder ratio or improper finishing of the wax pattern, can also lead to rough casting, indirectly cause distortion of FPD. Bending of long span FPD, what are the reasons for that? Thin crowns if we make, soft metal if we use for casting, heat treatment is not being done, porosity in the metal is already present, or there can be contaminated metal, can all lead to bending of a long span fixed partial denture. Next, let's come to the mechanical failures which can be causing that failure of FPD. So mechanical failure can be classified as retainer failure, it can be Pontic failure, or it can be a connector failure. So now in mechanical failure we have retainer failure. So retainer failure, how all it will happen? It can cause perforation, metal discrepancies can be there, facing failure can be there, that can fracture, that can wear off, discoloration can be present. Let's come one by one to it. Now perforation, how will it cause? Insufficient occlusal reduction if it is there, occlusal material is insufficient, contaminated metal if it is there, porosity in the metal work while casting due to improper maintaining of that melting temperature, improper pattern position, improper sprue design, improper location or parafunctional habits can cause perforation. What can cause marginal discrepancies? That is the selection of the margin. That can be failure due to gingival retraction not being proper, improper impression procedure, voids in the impression can also lead to marginal discrepancies, variation in the pressure application in wash technique, or delayed pouring of the dye material, distortion of the wax pattern at the margin can also lead to marginal discrepancy. Facing failure, as we know, it can be fracturing, it can wear off, or it can discolor. Different reasons being of these things are that too little retention is present, or badly designed metal protection, or deformation of the protecting metal, malocclusion, micro leakage, excessive oxide layer formation, or absorption of the oral fluids. Now oral fluid absorption will give you more that of discoloration, or other stains will give discoloration. Coming to the next one, there is a Pontic failure. Now the factors affecting selection and failure of the Pontics are the Pontic space, residual ridge contour, biological consideration, that is a ridge relationship, dental plaque if present, gingival surface of the Pontic, contact with that of the mucosa, mucosal contact, or it may be non-mucosal contact based on the Pontic that you have designed, Pontic ridge relationship, the material that you used to design the Pontic, biocompatibility, occlusal forces or metal substructure support. These are the way how Pontic failure can take place. Now what are the ways of a connector failure? Connector failure is going to happen because of improper selection of connector, of course, that we are selecting a rigid or a non-rigid connector, thin metal at the connector area, or incorrect selection of a solder material which we are using to connect, or solder gap narrow or wide, that is porosity present, insufficient metal around, or defective occlusal contact over thin connectors can also lead to connector failure. Now coming to the next one, there is gingival and periodontal problems. Now gingival and periodontal problems can happen because of what reasons? It is because of the margins that we will give. Now the margins can be either supragingival or subgingival. So what are the advantages of supragingival margin? They can be easily finished, they are more easily cleaned, impressions are more easily made with less damage to the tissue beneath. Restoration can be easily evaluated at recall appointments. Disadvantages being metal C is there. You can see some metal. Aesthetically, it is not indicated for anterior regions, not indicated in short clinical crowns. The proximal contact extends to the gingival crest. In case of root sensitivity, we cannot use supragingival margin. Coming to the subgingival margins, what are the specific demands for the subgingival margin? That is aesthetic demands. Caries removal from the cervical area to cover existing subgingival restoration if present, to gain needed crown length, to provide more favorable crown contour. Disadvantages being difficult for preparation, gingival management should be perfect. It is prone for soft tissue trauma, more prone for gingival and periodontal pathosis. It is difficult to maintain the oral hygiene, and metal margin can be seen through the gingiva in subgingival margins. Coming to the soft tissue problems, that can be generalized, that is not due to the bridge, or it can be localized, that may be due to the bridge or the fixed partial denture. Now, what are the causes for the soft tissue problems that can happen? It can be over or under contoured restoration. It can be narrow embrasures which are present. It can be over and under contoured crowns. Pressure on the pontic over the tissues. Loss of the contact can happen. Horizontal foot impaction can happen, that is due to the plunger cusp in the opposing arch. Marginal ridges at different levels. Wide occlusal table present. Trauma from occlusion. Parafunctional habits present in the patient. Acrylic facing in the contact with gingiva can lead to soft tissue problems, either a generalized or a localized one. Now, results of improper contact area, what happens is it causes displacement of the teeth buccally, lingually, mesially or distally. It exerts a lifting force on the tooth when placed too high occlusally. It disturbs the axial relation of the teeth, resulting in trauma, causes rotation of the teeth, and it causes injury to the investing structures which is present. Disturbs the coordination of the inclined planes and cusp, resulting in occlusal deflective contacts, and it causes vertical or horizontal foot impaction, that is if the improper contact is kept. Coming to the caries per se, now caries, recurrence of the caries can happen, and due to that also they can be, like we can see here, the abutment teeth which is there, if the proper oral hygiene is not maintained, subgingival margin nicely not maintained, then it can be failure of the fixed partial denture due to the caries recurrence. Now coming to the biomechanical failures, what does the biomechanical failure means? Now, biomechanical failure means that anything which fails because of the biomechanical structure of the fixed partial denture. Now, what is that? In case, what we know generally, why are the fixed partial dentures prepared? So that the occlusal load is transferred as that was in the natural teeth. Now, when the natural teeth is not there, of course, the force is going to transfer with the help of pontic, connectors or retainers to the abutment teeth and to the ridge. Now, if that particular connector or your pontic is not able to withstand that force, then the failure, that will be called biomechanical failure. How is that going to happen? In a long span fixed partial denture, as we know, the deflection force is inversely proportional to cube of the length. So that means if the length is 3, 27 times deflection force is going to come over the abutment teeth. So how much harm we are doing to the abutment teeth will also give a biomechanical failure to that particular fixed partial denture. Also, aesthetic failures. Now, per se, aesthetic failures, what are the reasons for aesthetic failure? The failure to identify the patient's expectation regarding aesthetics is important. Improper shade selection if done by the help of the dentist. Black triangles, like we can see here. We spoke earlier, if you are not giving a gingival porcelain in this area, you will see a black triangle. This looks very unaesthetic in the anterior region. Thick opaque layer application, if it is there, then the translucency will be gone. Surface blistering or a chalky appearance if it is present in these particular, that will also give a very unaesthetic appearance. Also, metal exposure in the connector or cervical and incisal region. In these areas, if there would have been a metal exposure, even that would have been unaesthetic. Failure to produce incisal and proximal translucency is also one of the important reasons for aesthetic failure. Improper contouring of the crowns can also lead, because if you are not giving a biplanar crown, it will not look natural. Similarly, failure to harmonize contralateral tooth morphology, that is contour, color, its shape, its angulation, its position, also looks very unnatural and hence look unaesthetic. And important is discoloration of the facing. The facing that we are giving, like acrylic used in the previous years, that acrylic used to get discolored soon. So discoloration of the facing also leads to the aesthetic failure of the particular fixed prosthetics and will hence lead to the failure of fixed partial denture. Thank you.